Very much, dear colleagues. It's a pleasure to be in Interlaken, beautiful day, and therefore we will talk less invasively in the next 15 minutes. Let me start by saying that death is inevitable, but premature death is not, and therefore we would like to prevent the premature deaths. And you have been introduced to the bleeding complications by Jan Borawicka. Let me say that 10% of the severe bleeding cases in patients over 70 years of age will die. This is a prospective study done in the northwestern part of Switzerland, so we will still die from GI bleeding in elderly patients, and therefore it's a severe complication. And we try to prevent that by different measures. Now I'll briefly talk about the GI toxicity of aspirin. I will talk about the dual antiplatelet therapy and GI toxicity, but primarily on risk assessment and preventive strategies. So aspirin is not new. It is more than 100 years old, and it has been used for pain relief in the beginning, but now it's used for many things. As you can see, very old things happened with aspirin-like substances, even proposed by Hippocrates. John Wayne was the person who then identified the pathways, and for the cardiologists, the irreversibly inhibits the cyclooxygenase, which then prevents platelet aggregation. And here is what happens in the GI tract. We have two different enzyme systems. One is COX-1, which is the constitutive one, and COX-2, which is the inducible enzyme. And in the GI tract, it's mainly COX-1, the prostaglandin synthesis, which produce mucus, bicarbonate, and prevent so that the mucosa is attacked. So this is protection of gastric mucosa. Now, aspirin and non-steroidals both inhibit COX-1, and therefore they induce a degeneration of the mucosal protection, and that's why ulcer formation is possible. You know that there are other side effects, but we mainly talk now about the GI tract. One of the most important messages from the start is the prostaglandin synthesis inhibition is clearly dose dependent. 10 milligrams of aspirin is sufficient to reduce prostaglandin synthesis by 50%. If you give 100 milligrams, you have 80% reduction in prostaglandin synthesis, and therefore the mucosa is no longer protected. Now this is quite an old study, but it clearly shows you the dose-response relationship, and therefore you have two major things happening in the GI tract. First of all, GI symptoms, which are not life-threatening, and then you have the GI complications, the ulcer bleeds, which are life-threatening. And you see all these ballpark figures, around 1 to 2%, as have been described before. Now here is the major effects in the GI tract. It's a dose-dependent increase in the risk of bleeding. 75 milligrams doubles the risk for bleeding. 300 milligrams is a fourfold increase. If you take a population-based study, and this is a survey, then the risk in patients taking aspirin is 0.6%. In the general population without any medication, it's 0.24%, so threefold lower. And if you look at endoscopic ulcer formation, then up to 30% will develop an ulcer. And especially the elderly persons have more ulcers formation because the natural prostaglandin synthesis is decreased, and therefore they are more prone to develop complications. Therefore, the risk assessment is the most important point if you treat these patients with aspirin. History of ulcer bleeding is the most important factor. Advanced age, here defined as more than 70 years, is the second most important aspect. Then, of course, the dose-response relationship. If you combine aspirin with non-steroidals, then you threefold or even quadruple the risk of ulcer formation and ulcer bleeding. And finally, H. pylori infection is still one of the factors. But there are additional factors clearly identified For instance, dual antiplatelet therapy or concomitant anticoagulation, a history of alcohol abuse, a new heart classification of 3 or 4, diabetes and renal failure. So these are additional risk factors for bleeding in the GI tract. Now, if you combine aspirin with clopidogrel, and clopidogrel has been advocated instead of aspirin because it should be safer, so if you combine it, then you increase the risk. So aspirin alone, in this study, 5%, the combination has 8.5% bleeding rate. And if you then add a proton pump inhibitor, then you can, here we chill in a bleeding situation. Aspirin has a higher bleeding rate than clopidogrel alone, but if you combine it, then you increase the risk. Again, different studies, but the ballpark figures are always the same. The combination is higher than aspirin alone, depending on the population you investigate. So what kind of strategies can you use to reduce GI bleeding? Well, risk factor avoidance is always proposed, but that's difficult because age cannot be eliminated, and the history of ulcer bleeding is also a fact, and therefore we have to rely on gastroprotective strategies. Let's start with H. pylori eradication, which is not so much a problem any longer in Switzerland, as H. pylori infection is clearly going down and is now below 10% if you investigate patients below 20 years of age. Now, just one example of a study, it's a 10-year follow-up, it's probably the longest study which is available. 3 cohorts were investigated. Cohort 1 were aspirin users with a previous ulcer bleeding story, plus H. pylori infection. H. pylori infection was eradicated, and then patients follow up for 10 years. Cohort 2 is aspirin users without H. pylori infection, but also with a bleeding ulcer history. And cohort 3 is the general average risk cohort, no previous ulcer, no previous bleeding episode, no H. pylori infection. And here are the results calculated per 100 patient years. So the H. pylori eradicated cohort has 1 case per 100 patient years of rebleeding. Cohort 2, no H. pylori infection, has a much higher risk. So you can see that if a patient without H. pylori infection bleeds on aspirin, he has a higher risk of rebleeding than if we've never had H. pylori before. And of course, the average risk cohort is the lowest, which is clearly below 1. So let's turn to acid inhibition, because that's probably going to be done. PPI for everybody. Well, here is the first randomized trial looking at aspirin 100 milligram a day plus lansoprazole, one of the PPIs, 30 milligrams per day versus placebo. And you can clearly see a dramatic reduction in the number of bleeding recurrences. These were all high-risk patients. All of them had had a bleeding episode before, and therefore you have this high risk of rebleeding if you don't give acid inhibition. Now, what happens if you combine clopidogrel and aspirin with a PPI? Here again, the combination, 8.6%. If you give aspirin plus a PPI, you have a clearly lower rate than clopidogrel alone without an acid inhibitor. Now, just to show you the results on the GI bleeding in this study, which you probably will much better than I do, you can see that there is no difference between the 2 compounds with respect to bleeding. But it has been proposed that PPIs could be detrimental if you combine them with prasugrel or clopidogrel. All retrospective studies suggested that. Now, in this Lancet paper, it was clearly shown that this was not the case, and this is the only prospective trial. And the important message here, this is stroke, myocardial infarction, or cardiovascular death for the 2 compounds, and you can see that there's no negative effect of the PPIs because the risk rate is not increased. And this is valid for all 4 different PPIs which are on the market. Now, if you go to the GI events under the same conditions, you can clearly see over time that if you have placebo versus omeprazole, in this case, that there is a benefit of giving an acid inhibitor to prevent ulcer bleeding formation. And this has no negative impact on the cardiovascular system, so the cardiovascular safety remains the same, but GI bleeding is clearly reduced. These are the details of the study. Composite of gastrointestinal events markedly reduced, no increase in cardiovascular events, no increase in myocardial infarction. So the benefit of the anticoagulation therapy remains, but you can prevent to a large extent the gastrointestinal complications. So in conclusions, you have to use risk factor stratification for GI bleeding in users of aspirin or antiplatelet agents. In low-risk patients, age below 65, no other risk factors, no gastroprotective strategy is necessary. Therefore, not PPIs for everyone, but just selectively to the patients who need it. If you have a moderate increase, moderate is fine, that's 1 or 2 risk factors, then age above 70, combination therapies with other antiplatelet agents, combinations with NSAIDs, combinations with oral bisphosphonates, or with systemic corticosteroids, there you do need a gastroprotective strategy. And finally, the really high-risk group is the patient with previous acute upper GI hemorrhage, with previous peptic ulcer bleeding, or in combination with anticoagulation, especially if he's above 70 years of age. These patients need gastroprotective strategies in order to prevent GI bleeding. Therefore, PP1 for everybody? No, only for the patients who need it. Stratify the patients according to the risk factors. Only those patients with defined risk factors for GI bleeding should receive gastroprotection with a PPI. Thank you very much.
Thank you very much, Christoph, for this very clear talk. Are there any questions from the audience? Okay, so it was so clear that, do we know the dose, or is the strategy defined?
Yes, 20 milligrams of pantoprazole or equivalent dose. All the preventive strategies have been done with the lower dose of PPI. No high doses required. There's absolutely no benefit.
Okay, thank you very much.